Thank you so much, Glenn, and thanks so much, Dr. Kim, for your presence at this session. So I'm Bromar Mukherjee. It's my honor and pleasure to host this joint COPSS and NISS webinar. As you know, that this biweekly webinar features the latest research that is positioned on the cusp of new understanding and analysis of COVID-19 pandemic data. So today it's my absolute pleasure to host Dr. Jim Yong Kim, who is a vice chairman and partner at Global Infrastructure Partners, a fund that invests in infrastructure projects across several sectors around the world. Dr. Kim is going to tell us about pandemics, poverty, and public health, the 3 Ps that are dear to my heart and to many of you. So this presentation today, or this conversation, will focus on Dr. Kim's 30 years of experience in battling pandemics in developing countries. A trained infectious disease physician, Dr. Kim has tackled multi-drug resistant tuberculosis, HIV, cholera, Ebola, and now COVID-19 in developing countries in Latin America, Asia, and Africa. He has also been involved in the COVID-19 response in the United States through the organization he co-founded, Partners in Health. Dr. Kim will first talk about his experiences in combating both poverty and infectious diseases throughout his career, as he told me in the conversation prior to the session, through some stories. And then we'll look forward to a robust question and answer session. But before we begin, I'd really like to tell you a little bit about Dr. Kim's journey, because this is an illustrious career that we all look with profound admiration. So from July 2012 to February 2019, Dr. Kim served as the 12th president of the World Bank Group. Soon after he assumed that position, the organization established 2 goals to guide its work: to end extreme poverty by 2030, and to boost shared prosperity, focusing on the bottom 40% of the population in developing countries. During Dr. Kim's tenure, the World Bank Group supported the development priorities of countries at levels never seen outside of a financial crisis. But before that, a physician and an anthropologist, Dr. Kim's career has revolved always around health, education, and improving lives of the poorest and the most vulnerable. He was born in South Korea to parents who had fled the violence of the Korean War and grew up in Iowa, where his father was a practicing dentist and his mother was a philosopher and theologian. Dr. Kim graduated from Brown University, then became one of the first students to study jointly for a medical degree from the Harvard Medical School and a PhD in anthropology at Harvard University. While at Harvard, Dr. Kim co-founded Partners in Health, a nonprofit medical organization that provides healthcare to poor communities on 4 continents. From 2003 to 2005, Dr. Kim served as director of the World Health Organization's HIV/AIDS department. He led WHO's 3x5 initiative, the first ever global goal for AIDS treatment, which greatly expanded access to antiretroviral medication in developing countries. Following his service at WHO, Dr. Kim was chair of the Department of Global Health and Social Medicine at Harvard Medical School, among his many academic positions. In 2009, he was named the 17th president of Dartmouth College, where he served until he was nominated by President Barack Obama to lead the World Bank Group. Dr. Kim was the first leader of the World Bank Group who did not come from the financial or political sectors, and the first who had personal experience tackling development issues in poor countries. Dr. Kim has received many, many awards. Among them, I must mention the MacArthur Genius Fellowship. He was recognized as one of America's 25 best leaders by US News and World Report, and was named one of Time Magazine's 100 more influential people in the world. We are so honored and so delighted that you are spending time with us talking about pandemics, poverty, and public health. So welcome, And maybe we can start with some opening remarks, Dr. Kim, and then we'll follow up with questions.
Well, Bramar, thank you for that very, very generous introduction. And I have to tell you that when my friend and your friend, Shi-Hong Lin, asked me to do this, I was very intimidated. And I thought, what could I possibly have to offer to this august group of people? In the social sciences, of course, we were in anthropology, both very admiring and very jealous of all the quantitative skills that the people in your group had, because what we did was our methodology was ethnography. So I decided that the best I could do was to offer you some of my ethnography of the experiences I've had trying to tackle these kinds of infectious diseases. COVID, of course, has been the worst pandemic in 100 years. And I was part of at least, I think now, 4 or 5 different groups that put out reports saying that precisely what we're going through could happen. And the latest one came out in 2018. And that report came out as a joint report from the World Bank Group and the United Nations, commissioned by me and by Antonio Guterres after the devastation of Ebola. We thought there's got to be something that we can do to prepare better. And so that report came out. It warned that this could happen, and in fact, it did happen. Now, if you think about, well, why did it get this bad, and why did the country that's supposedly the best prepared on Earth to tackle these pandemics, why has the United States done the worst? Here are just a few insights from my experiences. So the first major disease that we took on, that we had to really take on global authorities, was multi-drug resistant tuberculosis. Multi-drug resistant tuberculosis is the form that's resistant to the 2 most powerful and most frequently used drugs, isoniazid and rifampicin. And we found an outbreak, more than 50 cases in a town of 100,000 in Peru. And so we thought, oh my God, this is terrible. This is literally an outbreak of this deadly, very dangerous form of tuberculosis. We should treat it. And so we looked around, and because only poor people were getting tuberculosis, there had been no new drugs for tuberculosis in something like 30 or 40 years. And so what we had to do was use very old drugs, all off patent, very old drugs, but drugs that were very expensive because they were made in small quantities. And so we went to the local authorities and said, you've got an outbreak of drug-resistant tuberculosis. We've got to use state-of-the-art methods to treat them. Now, state-of-the-art meaning the best methods we have, but with old drugs. And what they told us, what we expected was something like, well, thank you for being so concerned about these poor people, poor patients in this slum. We really appreciate it, but we just don't have the resources to do it. That's not what they said. They said, if you treat a single patient for drug-resistant tuberculosis, we will kick you out of the country. So we were taken aback. We're saying, where does this come from? And it was understandable. The Peruvian authorities had built one of the most successful TB control programs from a point where there were very poor treatment outcomes. They had built a fantastic treatment protocol, a treatment system based on the DOTS system, the directly observed therapy short course, that was getting 90+% cure rate, and it was the most celebrated program in the entire world. And what they said was, we are very angry that you would suggest that there's anything wrong with our program. Totally understandable, because they were very proud of what they were doing. But we were saying, but you're giving them drugs to which we have documented resistance. This is not going to help. And in fact, at the WHO, my colleague Jaime Bayona at the time said, Jim, we can't solve this problem here. You have to go to Geneva and talk to folks at WHO. And this was in the early 1990s. And the folks at WHO said, no, you can't treat it. You can't even talk about it. It's not an issue, right? And I said, why? He says, we just don't have the resources to treat it. So again, an understandable objection. And then we kept going, we kept talking to them, and we said, so what is your plan for patients who fail therapy and who may have documented resistance. Well, what we do is instead of just giving them 4 drugs, we give them an extra drug, a 5th drug, right? So any infectious disease doctor will tell you, what's the first lesson you learn about tuberculosis, right? The first lesson you learn is you never add a single drug to a failing regimen, because all you're doing is putting yourself in a position to generate resistance to that 5th drug. Tuberculosis is such a tricky organism that it always requires at least 3 or 4 drugs. Now I think some of the powerful ones we can do 3, but at least 3 drugs to which the bacillus has known susceptibility. And so adding a single drug to a failing regimen is the worst thing you can do from an infectious disease perspective, but it was the official policy of WHO. Well, we did a bunch of things. We found out, hey, look, these drugs are all generic. And if we go to Indian or Chinese manufacturers, we can bring down the price dramatically. And we did that. So with very few phone calls, and I was in the middle of this, we brought the price of the drugs down 90%. We showed that you can treat drug-resistant TB using community health workers, and WHO changed its policy. And then a few years after that, it was the exact same situation with HIV treatment. Now, there are 27 million people receiving HIV treatment. I have to say that the single person who had the biggest impact on this transformation is George W. Bush. President Bush declared, and it surprised us tremendously, that he was going to treat people in Africa with HIV. That changed the entire conversation. But before that, everybody, literally 99.99999% of public health officials said it's impossible to treat HIV in Africa. And so in our little project in Haiti, what we did was we took drugs from Cambridge. There was a group called Cambridge Cares About AIDS that recycled HIV drugs. That when patients in Cambridge, Massachusetts, changed their drug regimen, they gave their old drugs to this group, and we took them to Haiti. And we showed, of course, that it shouldn't surprise us. Haitians are human beings like everyone else. We showed the same dramatic, what they called Lazarus effect of HIV treatment on those patients. And we just simply had before and after photos where people looked like they were literally dead to reviving within 2 or 3 months. And so we actually took those photos to the White House. Paul Farmer, my colleague, late at night with Tony Fauci, and we've been working with Tony very closely for now almost 25 years. With Tony Fauci, showed them to people in the White House. They were blown away, and they said, we've got to do something about treating HIV. And inside the White House, Josh Bolton was the chief of staff. There were people that were very, very committed to doing this. And more importantly, in later talks with President Bush, this was a moral issue for him. He took it very seriously, and he went way out on out on a limb and saying we can get drugs for $300 a year. We can do this. We can do that. It was world changing. And I've told President Bush this myself. I told his father this, that without that, I just don't know where Africa would be today in terms of its economy. I mean, if we had 22, 23 million people dying, nobody getting tested, Africa's economy, I think, would have collapsed by now. I mean, I'm now speaking as a World Bank Group president. But I have to tell you that up until 2003, the same people who have been saying, well, we're going to reach herd immunity soon. We don't, the contact tracing is impossible. It's, this public health mess that you have to use, military tactics, and we're a free country. You can't do that in the United States. Same people who are saying that were telling us it was impossible to treat HIV in developing countries. And so when I went to WHO, instead of arguing with them, we just created a goal: 3 by 5, 3 million people on treatment by 2005. And I was the one who convinced the Director General, whose campaign to win the Director Generalship, I ran for him. He was a Korean guy, Dr. J.W. Lee, and we just put a goal out there. And I can't tell you how many people yelled and screamed at me how stupid we were for putting a goal. But I think many people today would say that President Bush, of course, But that goal at WHO, if WHO had decided that it was going to go against HIV treatment, I don't know that many of the countries would have gone forward. And so, at that point, I thought, okay, things have changed. We've shown so much progress. We've gotten, we made a deal with the research-based pharmaceutical industry. We protected their first world markets, and then took generics made by Indian and Chinese companies mostly to Africa at very low prices. It didn't hurt their first world markets. They kept doing research, kept bringing out new HIV drugs. It was a really beautiful solution. And so I kind of thought, okay, I can hand over my work in public health to others because we've solved these huge problems so nicely. Then I went to the World Bank, and in 2014, I kind of watched the Ebola outbreak in West Africa going forward. And I thought, surely we've learned our lessons from MDR-TB and HIV. We're going to get on top of this. And I kept watching and watching. It started in December of 2013. And by June, I was hearing these terrible reports, and my good friend Joanne Liu from Médecins Sans Frontières, the Doctors Without Borders, Joanne Liu was on television saying, "This is awful. This is terrible. WHO, you've got to step up." And so I called my friend Paul Farmer, and I said, "Paul, what's going on?" Because the Partners in Health had started a project in Liberia, and he said, "Jim, I have never seen so much virus in the community before." He said, "We could be dealing with this in 30 years. I don't know. I don't know. I've never seen anything like this. I don't know how we're going to get this under control." And then I talked to Joanne, and Joanne said, "Jim, where are you guys? Where's the international community? Nothing's happening." So this was in July of 2014. I called my board at the World Bank. No money had been pledged. No sort of war effort had been declared. And so I said to my board, "Look, this is a existential crisis, not just for West Africa, but for West Africa and the world. What if Ebola starts in Delhi or Karachi, which very easily it could have, and it takes off, we're in trouble. We're in big trouble." So I got the board to approve $400 million for Ebola in the form of grants and ultra low interest loans to these three countries. Actually, it turned out mostly grants. And we approved it and had money flowing within about 2 weeks, which is the fastest, they told me, the fastest that had ever happened. And I don't think that made the difference, but 2 weeks after, the US government pledged to provide resources, and the British government, the French government, and we were extremely lucky to get it under control. And people ask me, well, why didn't it go to Lagos? It did go to Lagos. And I talked to Goodluck Jonathan, the president of Nigeria at the time, and he said, "You know how hard this was to get our 19 cases under control?" They said it cost them $1 million per case to get it under control. And the thing they had to do was just intensive testing, contact tracing, and it got it under control. And there was I think there were 30 or 40 CDC, US CDC people in Nigeria working with them. Again, if it had gotten out of control in Lagos, who knows what would have happened. And so again, I thought, okay, we're better now. We got this under control. We're going to be more prepared. And then COVID hit. And the thing that I couldn't believe in the US was how quickly the public health community gave up on the kind of intensive testing, contact tracing, isolation, quarantine, and then of course treatment of the ill. I just couldn't believe how quickly we were giving up. When there were 3 reported cases in Florida, they said, "Oh, it's too late. We can't do contact tracing." Part of it was leadership. Having a leadership in such intense denial was a huge factor. Having a leadership that didn't focus on testing was a huge factor. That was all really, really important. But the rapidity with which we gave up on contact tracing, and Shihong and I together had arguments with people in Massachusetts, because people in Massachusetts were saying, "Oh, you know what? We'll get to herd immunity soon enough. And once we get to herd immunity, everything will be fine." Right? And we said, "But you've got to do testing, contact tracing, these are principles that have been around for 100 years. They're the only principles. And when you have a vaccine, you add a vaccine to public health approach, you can actually get close to eradication. Although we've only eradicated one virus in the history of the world. And yet they were coming back at us and saying, it's too complicated. You can't do it. It's impossible. And I was just thinking, oh my God, we're back to MDR-TB. We're back to HIV, right? The nihilism in the public health community was something that just left me dumbstruck. And so Partners in Health is working on a contact tracing program that, of course, is receiving a lot of criticism because there's this intense suspicion that this is ever, quote unquote, doable. I'm going to end with just an insight from one of my heroes, Bill Foege. Last name is spelled F-O-E-G-E. And anyone who's been following infectious diseases for the last 50 years will know that he's one of the just living legends and heroes. Bill was the person who came up with the ring vaccination strategy for smallpox eradication. And it happened in India when they realized that in places like India and Nigeria, they didn't have anywhere near enough vaccine to vaccinate the entire population. And so what they would do is they would have incredibly intricate systems of notification. So if there was any report of anyone who looked like they had smallpox, and this was difficult because families often hid cases of smallpox because it created so much stigma for them. If there was any case of smallpox, and this was at a time, and Brahmar, you'll appreciate this. This was in the 70s in Bihar, right? In the state of Bihar, the poor state. And Bill Foege told me, we did testing, contact tracing. We ran down every contact in every village in Bihar with no telephone service, no electricity. We did that in Bihar. Don't tell me you can't do contact tracing in the United States. This is what Bill told me. And the other thing that Bill told me that really gave me chills was he said, Jim, they told me every week, oh, let's not worry about it. Once we get to 70 to 80% immunization in these states, this will just go away because we'll reach herd immunity. And he said it never happened. They got to 70, 80% in a lot of states, and outbreaks still occurred, right? And so, and there were states that had very low vaccination rates, 7%, and there were no outbreaks. And so he said, we realize we have to go after every infection to at least keep it under control, right? Now, there's an ongoing debate, and right now an argument still rages. There's still many people who are totally against, quote unquote, doing contact tracing. But I just think that's ridiculous because it's like saying, I'm really dehydrated, but I drank some water and it didn't make me feel better, so I'm going to quit water. You need contact tracing to get to the end game. You need contact tracing to get to the very low levels of infection that will make everyone confident to go out and engage, in social activities again. And if you do that, you can get back to pretty much normal. I've been doing interviews on things like baseball in Korea, right? And they asked, how did they do baseball in Korea? Well, they were able to run down every infection. And because of that, the baseball players were out in the community, but they carried their phones would be able to tell you if they were near anyone with the COVID, and they would watch the baseball players going home. And if they were walking into an area where there was somebody who had been infected, they'd get a phone call and they'd say, walk the other way, go the other way. They managed the virus in the way that it has to be, which is stay on top of every transmission. So they played baseball. Now in New Zealand, where they've done a very good job, they're having concerts with no one wearing masks, confident that if there is a case, they'll be able to run it down. Now, if you ask me, how would you do this in the United States? Well, you look at the experience of the World Bank. The World Bank has shown that conditional cash transfers have a very positive impact in many, many ways on the health of the families, on the educational status of the families, of course, on their poverty, because in fact, the solution to poverty is to have money, and the other thing that it does is it has the effect of being a fiscal stimulus. Poor people, if you give them money, they spend it, and they stimulates the rest of the economy. So there is a public health bill in the there's a public health portion of the $1.9 trillion stimulus that calls for creating a public health workforce. I think that's what we're going to need. And even if contact tracing is not effective now because there's so many cases, as the cases go down, if in fact, once we get to maybe 90, 95% vaccination, if we get there and the cases start to go down, that's when you want this trained contact tracing workforce, closely integrated, of course, with testing, with isolation, with quarantine, with treatment. Once you have that system together, then you'll be prepared for anything else that comes along. Because right now, my friends in the infectious disease community say, if every human infected with COVID is a petri dish for the mutation that could be the big one, the mutation that changes the game, completely, then we've got to get prepared. Now, let me say, I'm extremely optimistic about what's happened with the mRNA virus, the mRNA vaccines. But there'll always be a lag between getting the new mRNA vaccine and catching up with the variants. And so, building that public health system that can work with the vaccines and using some, it's some kind of targeted vaccination strategy could be very effective going forward. Anyway, I took too long. I apologize for that, but look forward to a conversation going forward.
Oh, no, you are just like, you touch so many important points. That's a part of our conversation. So I just wanted to make a couple of announcements. So please send your question and answer. I can see all of them coming already through the Q&A. And I also wanted to make an announcement that Shihong Lin, who organized this session, is receiving an award, the Adrian Couples Award from the Boston University School of Public Health. She was supposed to host this session as well in conversation with Dr. Kim. I am a poor substitute, but let us congratulate Shihong on her moment as well. So, Dr. Kim, one question that Shihong really wanted me to ask you is that, we have seen a series of natural experiments going on in the world in terms of economic policy as well as public health policy as well. So how do we synthesize this information? Why some countries were better, more successful in implementing public health measures, some with the fiscal policies? So how do we really synthesize as a leader of a leading organization of all of this information as we face the second wave or the third wave? What are some thoughts on that?
Very smart, very good people in the finance industry would say things to me that of course I was incredulous about, but if you think about it, makes perfect sense, and it's part of the reason that there's been such a delay. Going back, say, June and July, I was asking a question, and there were a group of analysts that I was working with from the Boston Consulting Group, and I said, what is the correlation between effectiveness of public health response and economic growth, or GDP, for example? And what they said was, well, there's really not an association. And I said, well, what do you mean? And they said, there's not an association. And so my good friends in the finance industry, see, you keep saying that public health response is important, but it's not, because there are countries that are doing just fine who have a terrible public health response. And so if you just dig a tiny bit behind it, what are those countries that are quote unquote doing fine economically? What are those countries that can print money, right? So the US, right? They are, the UK. Anyone who has a sort of globally accepted currency can print money. And so if you put into the economy massive fiscal stimulus like the US did, like the UK, like many of the European countries did, you can gin up, you can bolster your economic numbers while the pandemic rages on. Now, overall, the two fastest growing countries, the fastest growing OECD country was South Korea. Not surprising, they had such good control. And China, although it could be, it has chosen not to be in OECD, the club of rich countries. China, of course, has by far the fastest growth of any country in the world. And so, if you strip away the fiscal stimulus, you can see that the countries that are doing the best in terms of public health control are also having the most normalized economy, right? So, I mean, what are the implications of this? They're huge. The Chinese economy, those economies that are connected to the Chinese economy will continue to grow at very rapid rates. And so, the differential economic growth is going to be huge. Now, one of the things we have to think about is, well, we're going into uncharted territory in terms of levels of debt. And some people would say, well, interest rates are so low, it's really not a problem. Look, I'm worried. If this continues for another year, 2 years, what is this going to mean for the global economy? Well, I think the impacts have already been just devastating. And the thing that worries me most, of course, is what's going to happen to the poor countries. What's going to happen to the poor countries? I think the great hope. So far, I think many of the countries in Africa, for example, the median age in Ethiopia is like 19, right? A median age in Italy is, I think, well in the 50s. And so, just age differences, I think, have probably had an impact on relatively lower death rates in the African countries. But that could change, right? So I'm very worried about the overall economic impact. But I do think that the irony is that developing countries could actually do much better with a public health response than some of the developed countries, because they're used to it, right? The countries we work in Africa, they were prepared for this because they had to respond to Ebola in the past. They had to do vaccination campaigns in the past, and so I don't think there's any way of getting around building effective public health systems everywhere in the world. But the ultimate economic impact, as always, will fall to the poorest. I think already 150 million more people have been plunged into extreme poverty as a result of the pandemic.
Thank you so much for that question. So I have one more question from my own list, and then we'll go to audience question, which I think is flowing in. So we want to ask you, what do you think has been the vaccine rollout all over the world, and what is your projection about vaccine uptakes? Because we hear this certain percent of the population is vaccine hesitant, and we mentioned that if we are at 90-95% inoculation, will we ever get there? And how different countries in the world have done with vaccine nationalism and production and manufacturing, this whole circle of events. So what are some of your thoughts on that?
Yeah, there's, in the last a few months, I've had the opportunity and privilege of speaking to some of the leaders in the pharmaceutical industry. What Noubar Afey and Moderna did, I think, is remarkable. What Pfizer and BioNTech did, I think, is just truly remarkable. But it goes right down the line. The Sputnik vaccine, the Chinese vaccine, the response has just been extraordinary, and one that nobody predicted. I think that one of the smartest non-vaccine scientists in the world who know this world well is Bill Gates, and I worked very closely with him when I was at the World Bank, and he didn't think we'd get the mRNA vaccine in time, and he's been just over the moon happy about it, which is great. But we're living in a situation where the rich countries have contracted with companies for enough vaccine for 175% of their population, and the developing countries have contracts for only 25% of their population. And this is it makes no sense scientifically, because you don't know where the next more infectious, more lethal variant might come from, and so you really got to get the virus under control all over the world. And so I'm very worried about the situation in many poor countries. And so, but let me just focus on one area, which is Africa. So I've recently been in conversations. The fact that so many people are on this call, that so many of you now have taken to studying the pandemic, it's also true for people who've been in many different fields. And so there's one company that I've recently gotten to know that was really focused on making nucleotides for agriculture, and figured out how to make the RNA in bulk, and developed an enclosed system that can make the mRNA vaccine and all they need are the lipids. So they create everything inside the lab, and all they need really to import are the lipids, which makes it very tantalizing to be able to create a system that will do that in a country in Africa. So we're looking at that right now. But the reason we have to do that is because I just can't see the prospect for getting a lot of mRNA vaccine into Africa. And the mRNA vaccine is almost surely going to be what we use for boosters, is almost surely what we're going to be using for the new variants. For example, Johnson & Johnson, because when you give the vaccine, the vector itself, the adenovirus that you use as the vector, you develop immunity to the vector, so you can only give it once. So, the mRNA vaccines are going to be the future, but it looks like unless we have production capacity in Africa, it's just not going to happen. And, Brahma, we were talking earlier, so much of the vaccine for COVAX, the COVAX is a wonderful, really important effort to get vaccines to the developing world. Many of those vaccines were supposed to be produced by an Indian company, but understandably, the Indians are not going to release those vaccines because they want to use them for their own rapidly spiraling epidemic. So the technology is so great. In so many ways, the private sector, the scientists, biotech, Oxford, they've come through. They've done what they're supposed to do. Now, the big issue is distribution and having a strategy, right? And I know WHO is working very hard on this. They've said the right thing about the public health strategy all along. And Mike Ryan, who runs the epidemic response, a very good friend of mine, we work together on many, many issues. He knows what he's doing. They've said the right things. The world is not listening right now, and that's too bad. And there's a reason for that. I mean, when you're attacked by the most important member state, you have, it causes problems. But WHO could step up and give us, a very good strategy. I think they have one. It's just a question of whether we'll listen. And I think what's going to have to happen is just complete new thinking in terms of where we put production capacity. And this new technology, I think it can work.
Thank you so much. And, following the situation in India very closely, this vaccine nationalism, because they delayed their supply to the COVAX program, and that delayed the vaccination program in UK and several other countries. But again, they have their own needs as well. How do you balance between the two? And that brings me to some of the audience questions, which are very relevant. And Natalie Dean, who has also done exceptional work, is asking that, first of all, she thanks you for joining. And I agree with her that some of your writing last year, the New York Times and the op-ed, as well as the New Yorker article, really shaped our thinking in terms of all the public health tools that we have in our arsenal, and how to even talk, your article on how to prevent within family transmission and quarantine. These were really shaped many of our thinking. So she asks that you mentioned ring vaccination. Could you comment more on the potential role of strategic vaccination in response to surges in transmission? Like in India, they're talking about door-to-door vaccination, where they have high degree of transmissibility, possibly due to new variants. At a larger scale, should we be prioritizing vaccination in Michigan?
My colleagues in Massachusetts who developed the contact tracing program are trying to develop, what would this look like? Right. So it wouldn't be the same as smallpox eradication. It's a different kind of vaccine. It's a different kind of virus, different kind of transmission process. But I think the first step, first of all, Brahma, I didn't answer the question about vaccine hesitancy. Okay, and I just will tell you this. So when you're really old when your students are running large companies. And so one of my students is Vasant Narasimhan. Vas is, he and his wife Shrishti were both students of mine. They worked in Partners in Health projects in Peru. He's now the CEO of Novartis. And Vas told me that vaccine hesitancy is his greatest concern. There were surveys where up to 70% of French people expressed, skepticism at getting a vaccine. We'll have to overcome that. But the reason I start with that is because, we've done vaccination in very difficult situations, for cholera, for example, for Ebola now. And what we found is that very few people trust people like you and I, Bramar. They don't trust experts, but they trust their neighbors. And so we found that it's very important to develop programs where you can talk to somebody who looks like you, who talks like you, who speaks the same language as you do, and who tells you, yes, it's a really good idea to get the vaccine. And so that's really the core of whatever targeted strategy that you'd have. You have to, first of all, what we've been hearing is that when you do it just based on, say, demographics, your age, underlying conditions, there's a great ethical, moral foundation to that. And I think that's important. I think the fact that many states, my home state, New York, they were very, very careful about that. It would prevent the kind of hopping the line that rich people would have, and the fact that they're really going after some of the rich people who have hopped the line. I think it's good. I think it's a good thing. But you end up, for example, having communities with almost no virus being extremely well vaccinated, and having places that have a lot of virus with very few people vaccinated because they haven't yet met the criteria. Right? So you start with a simple idea of in the United States, the so-called Willie Sutton principle, and that's they ask Willie Sutton, why do you rob banks? And he said, well, that's where the money is, and so you should go to where the vaccine is. And so you probably wouldn't, when you find a case, you probably wouldn't right now do extensive contact tracing, because it would take it is too time consuming. But what you could do is go forward and, for example, vaccinate all of their contacts, vaccinate all the contacts, just go in a circle around the positive person, but also really focus on the places that have the most vaccine, the most exposure, and do it in a thoughtful, strategic way. There are, Malaysia is doing it right now. I think many states in the United States are also talking about it. And I do know that the CDC is looking at this very carefully. They're really thinking about what could be a recommendation in terms of a targeted strategy at using the vaccine in the most effective way. I wouldn't, people like Bill Foege, Rochelle Walensky is a fantastic, I think, choice for director of CDC. They're as good as they get, and so I think that that's going to have to happen. I think the developing countries have no choice but to do that, and so the question is, what is the right strategy? And my guess is that many of the people on this call could be extremely helpful in doing the evaluation of different strategies to figure out what is the most effective.
Thank you so much. There are two other questions related to vaccines that I'm going to couple together and ask. One is that, do you think that vaccinating children and teenagers is a good strategy, and what is your thought on the data for that? And the second one is to comment on Israel's success on vaccination, and what are your thoughts on that?
Yeah, in talks with various with CEOs and the like, there's the sense that the data will become available very quickly, that vaccinating children could be helpful. Now, what have we learned? Asymptomatic people can transmit the virus very nicely, and we're still waiting for the data on whether the people who are vaccinated can also transmit the virus. Now, I talked to a lot of different people, and the sense is that it's almost certain that the amount of virus you have in your nostrils, in your throat, et cetera, is going to be lower. The titer will be lower, so that you're probably less likely to transmit. But it's not zero. The titer is not zero, and so I think it's fine to vaccinate children, and because it's the urgency of it of getting the vaccine out that forced us to use as an endpoint just symptomatic disease. Right? What if we had more time, if we had more money, what you could do is you could have tested everybody continuously to just get a sense for the infectiousness and not just the number of symptomatic infections, but the number of overall infections. You could have gotten a sense for that, but there was just such urgency to get the vaccine out that we didn't have time to do that. So ultimately, look, these are unbelievably good vaccines, and I think we should find a way to get them to everybody. That would give us the best hope of really tamping down infections, but it wouldn't move me off of taking the public health approach. Now, I don't know the latest data on Israel. I think it's very interesting that they have had so much success. My own recollection of it, and maybe somebody online can give us what the latest, it means I haven't really looked at the data for 3 or 4 weeks. Do you know?
Actually, the question actually does put in some numbers. In 71.3% of its population with 1 dose and 65.1% with 2 doses.
I think there's really good data that after 1 dose, with the mRNA viruses, the vaccines, that they're getting pretty good protection, a few weeks after a single dose. What's happening with the rates? I just haven't seen them in the last 3 or 4 weeks. Mm-hmm. Do we know?
I did not follow the data in the last couple of weeks because I was just.
Yeah, I think it's going to be a great test case. I think it's going to be a great test case. And if getting to that number really, and we're really talking about not eradication but elimination, of course, right? Can we eliminate COVID-19 as a public health problem? And if Israel is successful at doing it, I think that's incredibly hopeful for the world, mm-hmm. right? But again, I would just say, I remember what Bill Foege told me, which was that getting there, it never stopped the smallpox, right? Getting to that 70 to 80% did not stop smallpox. And so, will COVID act like something that if you get to 70, 80%, the hospitalizations drop so much that you feel like you can live with it? That would be great news. Even so, I think a big mistake would be to say, okay, so, all these crazy people that have been saying that you have to build a public health response everywhere, all these crazy people, go back into your holes and stop making us scared and shut up. If we do that, I just think that we'll be unprepared for whatever else comes, right? We'll be unprepared for that, extremely rare, sort of difficult to orchestrate mutation that comes up with something that's much more lethal and much more transmissible. That is possible.
So thank you so much. I want to ask one question about, because we have been talking a lot about public health, I want to ask at least one question about the US economy. So this question is, in terms of predictions for the US economy, do you foresee a net widening of income and wealth inequality or a net narrowing?
I'm not sure, because I think you have to take into account the massive fiscal stimulus. But I cannot imagine how it couldn't widen. I think it will. I think that the wealth gap will widen. And let me just give you just one brief example of why I think that might be the case. So the stock market has been booming. Of course, it's been doing well, and a big part of it is because the treasury rates are so low. The Fed funds rate is so low that people are trying to find return somewhere. So you see a lot of inflated stock prices, and so the people who own these stocks are not poor people. I mean, they're the wealthy people, and they've been doing just fine in the pandemic. So these kinds of crises, unfortunately, very often lead to greater inequality, and I think we're going to see that both between countries and within countries.
Thank you so much. So there is another couple of questions about lessons learned, and I'll just combine them together that we are blindsided with many things with the SARS-CoV-2 infection. So how can we use this example as a teaching model to set up more resilient and robust and high alert public health systems in the United States and probably all over the world? How can we do that?
I think the good news is that we have some really important success stories around the world in very different kinds of societies, right? So, Taiwan, what did Taiwan do that was so effective? They put a travel ban on, and as a public health expert, right? And this is what Tony has been criticized about. Look, every public health expert thought they knew two things. One, travel bans aren't helpful, and two, masks aren't helpful, right? Because there had been studies done on masks, and I remember telling them, look, the thing I remember is that masks don't help a lot because it in fact can hurt because people put their hands and moving the mask around, and there's a false sense of security. There are all kinds of reasons saying the mask didn't work, and there are all kinds of data and experience suggesting that travel bans don't work. So we know now that that's not true. And with a virus like this, the countries that were able to effectively put in place travel bans had good outcomes. Australia and New Zealand were very tight about it, and it's one of the reasons why I think people think they did better. And the other thing we learned is that masking, even double masking with a shield, these things are all helpful. Right? And so I think this is new information, and the kind of insights we have on social distancing, I hope never leave us. Right? But the other thing is that it's almost I don't know how to say it. It's almost a solidarity test for societies. And it's a trust test. Do you trust your government, or who do you trust in telling you what's going on and what's happening? South Korea is, of course, a country I know very well, and it's a almost hyper democratic society. Every former president, bar none, is either dead or in jail, right? And they have fist fights on in the parliament, which is embarrassing for all Koreans, but they do. It's almost a hyper democratic society, so you get very little leeway to make mistakes. And so in South Korea, it's been a constant struggle back and forth. They have things pinging on their phones all the time, telling them where cases are. They're very strictly watched in terms of quarantine and isolation when there's a positive case. They have an incredibly intensive system of contact tracing, and the professional contact tracers are relatively small in number, but the army, there's a conscription process where every young man has to go to the army. The army is trained to do contact tracing, and when there is a big outbreak, they have folks from the army coming in helping with the contact tracing. And so the system exists. The economy is moving back to normal, and they've been able to do it with a combination of technology, and I think the most important thing they did was communication. Their public health experts communicated just extraordinarily well in the early phases of the pandemic, and a good bit of why they responded so quickly and so effectively is because they had a terrible response to the MERS outbreak in 2015. They just fumbled that completely. Now, luckily, MERS, while it's much deadlier than COVID-19, it also transmits much more slowly. So they were able to get it eventually under control, but that scare really led to them bolstering their public health response. And they were able to use things like access to credit card records, so they know where a person purchased something, and then they would do contact tracing around that particular area. Whether that could ever work in the United States, I'm not sure. But I think in the United States, we have to just have a conversation about this. This is going to happen again. We now know that a virus can do this, although we always knew, but now everybody knows that a virus can do this. We have to have a conversation about the kind of system that will work in the United States that will allow us next time to chase down every infection and to get to where the successful countries are, where they have, zero community transmission for, X number of days.
Thank you so much. We have very little time, but I want to ask this question because you touched upon this, but we did not get a chance to really talk about strategies that political leadership and also political interference in terms of suppressing data, messaging, really reporting your analysis has been a problem, particularly in developing countries. So have you dealt with this before? And do you have any advice for particularly data scientists who are working with this imperfect data and government pressure, who are limited by this whole data deficient environment as well as politically influenced environment?
Well, let me tell you just two stories about this that I think. First of all, let me just say I have such enormous admiration for those of you who have been doing such important work on collecting whatever data is available in developing countries and making sense of it. So, for example, at the World Bank Group, we started something called the Human Capital Project and created a human capital index. And the data was incomplete. We ended up only being able to rank 157 countries. But for example, we were able to do something that we called learning adjusted years of schooling. An amazing piece of data that because there's enough testing in 157 countries that we felt that we knew how many effective years of education someone was getting. And so, for example, the kids in Singapore, if they went to school for 12 years, were getting something like 11.4 effective years of schooling, the best in the world. But in Malawi, 12 years of school gave you about 4.5 years of schooling. And it was just an extraordinary effort by data scientists to be able to get useful data out of very incomplete records. And so I think you'll always have that. But it reminds me when I was at the World Health Organization with J.W. Lee, my friend and someone I just admire enormously, the person who probably was most responsible for getting these huge numbers of financing for HIV was Jeffrey Sachs. So I brought Jeff in to see the Director General, and he said this, which was, I think, just great. He said, you need to just put out data on things like how many people are getting treated, how many people are doing this, how many people are doing that, to push forward your agenda. And JW said to Jeff, well, but what if the data is incomplete? What if it's no good? And Jeff looked at JW and said, let me just tell you, it doesn't matter at all if it's right or wrong, if it's complete or incomplete. You have the best data out there, so just put it out there, and stand by it. JW laughed and he said, you're revealing too many of your trade secrets. Right? He said, you're giving yourself away. And it then reminds me of a story that my mentor, Leon Eisenberg, once said. And on data, we have to understand that this is part of a longer conversation. And I know you guys are really committed to getting the best possible data. But he tells the story of 3 baseball umpires. Right? I can't believe I'm telling you this story, but I will anyway. So 3 baseball umpires. The first was a positivist, the second was a relativist, and the third was a realist. Right? So when they asked the first baseball umpire, the positivist, well, how do you decide what are balls and what are strikes? And he says, well, some are balls and some are strikes. I call them like they are. They go to the second umpire, the relativist, and they say, well, how do you call balls and strikes? He says, well, some are balls and some are strikes. I call them like I see them. And then they go to the realist, who they ask, well, how do you call balls and strikes? He says, well, some are balls and some are strikes, but they ain't nothing till I call them. Right? So this is how the world works, right? you guys take incomplete data and do the very best you can to give your interpretation of it. And it's so important for us. I mean, Xihong's early studies of Wuhan, right? And you know, it's been criticized, it's complicated, but the fact that she did it and put it out there, and among the implications were that you have got to be serious about contact tracing, isolation, and quarantine. That was incredibly important. Now, you know, where that data ends up, you know, how we you know, interpret it overall, I'm not sure. But it was so important in waking us up, and it for me, it fit in exactly with my now 35 years of experience in tackling pandemics. So you guys have to call them. You have to call them. You have to bring it to life. You have to not give up on data in developing countries because it's of poor quality, and you have to help us develop data science in every corner of the world. And you know, it's going to be debated. There are going to be ideological debates. But what I would really warn against is that so many of the public health experts that you see on TV saying that this or that is not possible, just ask yourself a simple question. Have they ever tried it? Have they ever tried it, right? And so it drives me crazy listening to these experts saying something's not possible, you know, when they've never tried it. And so listen, you know, Bill Foege says, I'm going crazy. You know, they're saying it's not possible to do contact tracing in Florida. I did it in Bihar in the 1970s. Don't tell me it's not possible. So understand that, you know, academics who, you know, we are taught, and look, I lived most of my life in academia. I was president of a university, and we are taught to be skeptical. You know, we are taught to be doubtful. We are taught to question. But I think in this case, you have academics who have never tried in any kind of difficult setting to get a program running, saying that things are not possible. They should shut their damn mouths, is what I would say.
On that note, thank you very much for that advice.
With
I
great
know that
respect, with great respect for the academics, with great respect, I must say, yeah.
We are 4 minutes past our time, and I'm mindful of the precious time that you have shared with us. And I just want to thank you. I feel like I could be in conversation for the rest of today with you. I personally learned so much and enjoyed this so much. And thank you for being a great leader, a great scientist, and a great human being who has always made the impossible possible. So there are many questions in the chat. I apologize to those audience whose questions did not get asked. We'll take a copy of this and share with Dr. Kim. Thank you all for joining us. Dr. Kim, you have the last word, because this whole last year we have seen economics and public health being pitted against each other. And as we look into the post-vaccination world and try to balance between our economic recovery as well as public health risk mitigation, how do you envision this world?
You know, I've been saying all along, you know, this notion of economics versus public health is just fundamentally misguided. And, you know, at some point, the capacity to do fiscal stimulus by printing money will run out. And so, you know, it's right now, it's magical thinking, it's wishful thinking to think that if we get to 70, 80% vaccination, everything will go away. It would be great if it did. We cannot count on it, right? We cannot count on it. And so any rational, you know, thoughtful society would say, okay, it would be great if that happened, but here are people who've got direct experience saying it might not. What do we need to do to prepare? So to me, the answer is, if you start a massive, you know, public health create a massive public health workforce, you take the stimulus money and you pay people for doing their job. In Massachusetts, we pay $32 an hour to be contact tracers. They're now trained, and the workforce, you know, will expand when it needs to contract. Well, we've trained over 3,000 people to be contact tracers. This is a public health effort. It's fiscal stimulus. It gives dignity to people who are out of work, right? And there's more than enough money to do that in the United States. We know that now. Even if it costs a couple $100 billion, we've already put $5 trillion into fiscal stimulus. It's nothing compared to what we've already spent, right? So I think that's the great hope, that if we wake up and say, hey, you know what, we could do something that's really good for people who are out of work, but also really good for public health. There are models all over the world. We can pick and choose from the things that have been effective in other places, put it together, and get our economy back up and running. I think this approach that says, you told us to lock down, it makes no sense. We're going to just take our masks off. We're going to go back to work and everything will be fine. It would be great if that were true. But I think this virus has shown us that, every time it has a chance. I mean, you guys know the data, of course. The 99.9999999% of mutations will be deleterious. Will lead to a certain death. But there's no reason why a single mutation isn't going to lead to something that is infectious and more lethal. There's no reason against it. And so humility in the face of this virus is what we need more than anything else. And so let me, on behalf of all of the people like me, people like, when I was president of the World Bank, who've used your data, I've looked at some of the work that you have done and just been, incredibly impressed with how you were able to find patterns and implications and conclusions from incredibly messy data sets. And for those of you who've done that, I just want to say that people like me don't think that the president of the World Bank doesn't appreciate what the work that you do. We do, and we try to read it. We try to make sense of it. I came into medical school in 1982, and the very, very first shoots of evidence-based medicine were starting then. Evidence-based medicine is not like 100 years old. We were just beginning to talk about it in the 80s and the 90s. That's really when it started. So the fact that you guys are engaged with trying to understand this pandemic, I think it's a very important development. It's new, and I would just beg you to keep at it.
Thank you so much for that encouraging message, Dr. Kim, and it has been a real pleasure. With that, we'll conclude the formal portion of this webinar, and like to thank Shihong again for bringing Dr. Kim to this community. And as we all learned, with imperfect data, imperfect circumstances, we are going to try to fight this pandemic as best as we can as a scientific community with data, science, evidence, and determination. Thank you, everyone. Have a wonderful week. Thank you, Dr. Kim. Glenn, I think we can conclude the recording.
Thank you, Brahmar. And thank you. It's been an honor, Dr. Kim.
Thanks very much. And I hope we can keep the conversation going if folks are interested. The thing that I regret most is I would love to have all of you so I can ask you questions. You're closer to the data. I'd love to have a chance to learn from you about what you're seeing.
No, that I think definitely that just by modeling, as you said, the data from India was very sparse and spotty in the beginning, but we have set up an app which has been modeling it for the last 1 year. And you cannot give up, right? So you will never have the perfect inference, but you can always strive for the less imperfect one. So I really, really enjoyed this conversation. Thank you so much for your time and for everything that you have done for humanity.
One last thing, we got a capital increase at the World Bank Group in the spring of 2018, and I gave all of my top staff a little card, and it's a picture that you may know. It's a bird of prey, and there's a frog that is being swallowed by the bird of prey, but the frog takes his hand and grabs the bird around the neck, right, to stop it from swallowing the frog. And so it's stuck inside the bird's neck, but it's grabbed the neck. And underneath it, I wrote, never give up. Right? So everyone doubted that we would get the capital increase, and certainly in the last administration, but we did. And it was all about persistence. And so I know that this group of scientists are among the most persistent in the world, and keep at it.
Yes, that's what makes science so beautiful and spectacular as well for all of us. So Glenn, I was wondering, there are many questions that we did not get to. Can we save the chat and share it with Dr. Kim and Shihong so that we can see if we can get back to some of the participants?
Absolutely. Absolutely. Not a problem. Yep. I'll send that along to you.
Thank you.
Bramar.
Thank you.
We'll conclude the session now.